situation, I know he'll steer me clear. And if I should ever lose my direction, keep a little bit of Zion in mind. Although I've been told doors may close, but others open sometime. Although I've been told doors may close, but others open sometimes. And even when you think you've had enough, oh, child, you're the strength.
Good evening again. I am Selwyn Collins, your host of CWS Conversations with Selwyn. The lovely lady next to me is Dr. Sharon Griffith. Sharon, good evening.
Good evening, Selwyn.
Thank you for coming.
Oh, you're welcome.
I'm so very happy to have you here. I want to just go into your bio a little bit, just a little bit. I mean, it's long and it's extensive, so I'm just going to give a synopsis, right? Dr. Sharon Griffith, MD, FACOG, MD, Columbia University College of Physicians and Surgeons, New York, BA in Biology, cum laude, Brooklyn College, licensure and certification, diplomat of the American Board of Obstetrics and Gynecology, 2002 to present, medical license state of New York, intern and resident in obstetrics and gynecology, and blah, 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 blah. Wonderful. sorry for that, Sharon. I just am anxious to get started here tonight. And so, congratulations on all your accomplishment. It is a pleasure to have you on CWS. If you weren't a physician and surgeon, what would you want to be?
Oh, that's a tough one. I've wanted to be a physician for as long as I can remember. That's a tough one. I give it some thought, and I don't know, some sort of person who has an imaginative career, something that needs a lot of imagination, so I guess I can't think of it. I don't know. I wanted to be a physician for a long time, I think since I was about 6. So I hadn't really given much thought to anything else.
Mm-hmm.
It would probably have something to do with, I don't know, service of some kind, you know, making an impact somewhere, probably in public health,
Mm-hmm.
being a public advocate of some kind for social causes, probably, because I think that's where there's a great need. So,
Where did this desire to be of service to the public come from?
I think it kind of evolved out of wanting to be a doctor.
Mm-hmm.
You know, I think when we were children, especially coming from the West Indies, usually your options for a career are sort of delineated as you're going to be a professional of some kind. And so I don't think I was any different in that regard with regards to what I would do. So I think somewhere along the line, initially I remember I wanted to be a nurse.
Mm-hmm.
I've been reading a lot of books about Biggles. I don't know if you know who that is, but he was some aircraft pilot in the war, and there were nurses in the field hospitals. It all sounded so very exciting. And then there was a nurse in another story called Cherry Ames. She was a student nurse. But slowly the realization started to dawn on me that the nurses took a lot of orders from the doctors. And so I think that sort of modified my objective, yeah. So.
As I listen to you, one of the things I'm slowly realizing is that because we grew up together and I know you, I have to really restrain myself from asking certain kinds of questions and to try to be as impartial as possible. So with that, what prompted you to want a career in obstetrician and gynecology?
In obstetrics and gynecology. So the way usually it works in medical school is that once you've decided to go to medical school and you're there, you usually at least traditional American medical school training usually requires that you have 2 years of basic sciences, after which you spend the next 2 years of the 4-year program doing clinical rotations. It's usually during those rotations that you try to determine, after you've had exposure to certain subspecialties of medicine, what it is you think you might want to focus on in the future. So doing my regular rotations, you go through the usual rotations of internal medicine, which are the doctors who, manage your blood pressure, your diabetes, that sort of thing. Those are the medical specialties. And then there are the surgical specialties, where basically you get to operate on people. OBGYN, fortunately, is the one specialty where you can actually do both, because we take care of women who are pregnant, but who need medical care, because any medical condition that occurs in a non-pregnant state also can occur while a woman is pregnant. So we need to be able to be efficient and proficient in managing women for medical conditions, and on top of which we are also surgeons. So when I was, in medical school looking for a residency program or deciding on a specialty, the thing that was attractive about it was that I didn't have to dedicate all my time to just internal medicine aspects of diabetes, hypertension, fevers, kidney disease, that sort of thing. There was also surgery, hysterectomies, even C-sections, which are surgical procedures that are done on pregnant women. So it was the best of both worlds. So it was very attractive for that reason. I think that's why it's attractive to many gynecologists, obstetricians, because you still get to practice the medical surgery specialty as well as the surgical aspects.
What is it about OBGYN that really appeals to you?
There are a few aspects. I think the most important thing is that I'm taking care of women. I have no male patients, except by default, if the partner of a pregnant woman, perhaps with a partner of even a non-pregnant woman who may need consultation, but in general my patients are all female. So that's empowering, because I believe that in many, many ways our womankind, they need some guidance and special attention. Not to say that they couldn't get it from a male gynecologist obstetrician, but there has been a tendency, more so now than even before, for the college, which is made up of the persons in the United States who practice OBGYN, to be now predominantly female. When I was in residency, I think that was when the shift was happening to where there were more women gynecologists OBs than they were males, and that was definitely a shift from, I guess, the time when our parents would have gone to see a gynecologist. That person most likely would have been male. And not that much is necessarily lost in that relationship, but women sometimes prefer to be seen by someone who's female. Sometimes not. Sometimes the opposite is true. But it gives me an opportunity to be able to take care of women. So that's what's most appealing. Trying to be able to give some, advice, supervision to women. Usually I'm working mostly with women of the underserved population. So women who are either underinsured, not insured, who are working poor, and to be able to provide healthcare services to them, that's really what's important.
Let's go down your timeline a little bit. What books or stories did you enjoy as a child?
Wow, I was a real bookworm, actually. I came from a very evangelical, seriously Christian upbringing. And my father was like an evangelical preacher from the Assemblies of God. So I went to church almost every day. I even did my homework at church. Yeah, because there's nowhere else to do it. So what I did, because I had a lot of restrictions growing up about things I could do, movies, parties, that sort of thing. So I read a lot. I read all the Hardy Boys, all the Nancy Drews, the American series, the British series, the Enid Blytons, the Five Finder, all of those. I did a lot of reading, in fact, actually, when I was a kid. So what books? And then, as I mentioned before, at the beginning, there were the stories about the war and the airplane fighters. I still remember those. And stories about nursing and nurses, pretty much.
Talking about your dad and being an evangelical preacher and so on, what do you recall any special words of wisdom that you received from your parents that have shaped you today?
Well, I not specifically words that I can quote, but ideas.
Ideas.
Ideas about being conscientious and trying to be the best person. Ideas about following through. And it, being in a Christian household, I mean, there was really a really straight line between what was good and bad. I mean, almost everything was bad. So there wasn't much wriggle room, to not behave. So yes, those times were very strict, and so yes, you were taught not to lie. The usual things that we're taught, I guess, in Sunday school. You're taught not to lie, to steal, to cheat, and I think those things have pretty much carried through for most of my adult life.
Give us a glimpse into your world. For us as a 12-year-old, 12 years old in high school, and then as a young adult in college.
Wow.
Should we raise? You know what? I'm gonna do this. Gonna do this. I promise to stay out of it, but not as a 12-year-old, as a 14-year-old.
Okay, that's
in high school.
Worse. Okay.
Yeah.
All right. So, as you know, I went to Bishop's, and so that was also the time, I guess, in my life where things were changing for me as well. So, you know, as the other people who are listening who've been to Bishops and schools of that ilk would recognize that, you get there based on your performance, and then you're expected to do well. And there are lots of expectations, I guess, for persons who go to school, high school, to do well, especially because, as opposed to now where there's so many other opportunities for persons to have alternate careers or to pursue different career goals, it's not necessarily so easy in the West Indies or in that time, or at that time. So it was sort of delineated, you were supposed to go to high school, do your O-levels, do your A-levels, and then go be the doctor, right? That was the plan. Except that somewhere along the line there was some sort of, I don't know, short or some sort of detour that I needed to take. I think because I was coming into my own as an adolescent. Looking back, I can say that. There was an opportunity, or I should say things happened where I was no longer being so strictly monitored by my very religious father. So I think I took advantage of the situation to just really learn about the world around me, to put it mildly. And so, much to probably the consternation of the high school teachers, I really didn't pay a lot of attention to my schoolwork, to be honest. It wasn't that I don't think I was stupid or dumb. That clearly wasn't the issue. It wasn't that I wasn't relatively intelligent, but there were just other things to do. Meet friends and be able to go out. And so I spent 14, that would be the time when I first went to the movie theater for the first time in my life. So those sorts of things took precedence over biology and geography and geology or whatever it is we were supposed to be learning at that time. So then, fast forward to getting through O-levels, A-levels, and moving on to the United States, which gave me the opportunity, of course, to backtrack and just reassess my situation. That's actually one of the good things about the United States. Compared to places like, I imagine, Canada or the United Kingdom, where, your ability to progress oftentimes is already determined by your lack of or your ability to have conquered your O's and A's. The system here, the education system here is a little bit different in that, the O's and A's are important enough if you have a knowledge of what you did back then, but you do get a chance to basically start over, more or less. And so that's what I did. I knew that it wasn't going to obviously happen, that I was going to have a career in medicine or anything else, actually, if I didn't buckle down. So that's what I did. I started to go to college and started to actually pay attention. Some of it was easier, I should say, because I'd actually done the work. It's just that I hadn't been paying a lot of attention.
Do you remember your favorite subject in high school?
In high school? I don't know, no.
Okay.
I didn't really have a favorite. I did bio and chem for A-levels. Biology was pretty interesting. I became a biology major in college, so I guess that would have been the most interesting subject.
Biology. How do you deal with a patient who questions your experience because you look so young?
Thank you for saying so. It doesn't come up as much now as maybe it did before. There's I don't really acknowledge it. I just smile nicely and, try to address the issues, the reasons why they are there. I mean, I try not to make it about me. But yes, there are some women, especially older women, who challenge. As I said, not so much now as perhaps, say, 8 or 10 years ago. I think I look more mature now, but maybe a little while ago, yeah, sometimes it was, people would ask questions. But then it's not always clear whether they're asking questions because I look young or if there are any other characteristics that they are questioning. So it becomes difficult to determine.
Can you tell us a particular challenge? Let me see how to frame this. A particular challenge as in your field that you had to overcome.
Yeah, there are a couple. I think sometimes it's there's this concept in psychology and psychiatry about transference and countertransference, which is where you put the other person's feelings on yourself, you absorb them, or that you start to generate what you're feeling off of them back at them, right? So there are those instances. So sometimes it becomes difficult to actually determine if the feedback that you're getting across the table is what is the reason, because so many patients have their own they come with their own issues, and sometimes it becomes a little bit difficult to try to figure out if the issues were there before they walked in the door or if they became amplified after they saw me. Yeah. I've had people who have sometimes asked me things, like in a very nuanced sort of way, subtly. Where did you go to medical school? I hear an accent. Where are you from? I mean, those things come up. I'm sure it happens to other people in other specialties or other fields, actually, of work, where it appears that you are a foreigner. So it poses a challenge in a lot of ways. Sometimes being a foreigner implies that to some people that maybe you're not as smart or not as worthy or not as competent or capable. And then for other people, it can be alienating because even though you may look similar, you are different. So there are lots of challenges in trying to negotiate the patient-physician relationship during especially the first meeting. So that continues to be a challenge because you're never sure what sort of response or what sort of question or problem or preconception the person that you'll be meeting with already has. So that's one of the biggest challenges. Part of it also is because, about approximately every 15 to 20 minutes or so, we are engaging with another person, with another set of expectations, complications, questions, interactions, and so it's a constant challenge to remember to be in the moment and to, not bring things with you. You need to be as much as possible an open book, but that sometimes is challenging.
I'm going to bring your parents back in this conversation. Many, including me, say that you have a friendly, warm, and easy to get along personality. From which of your parents do you believe you inherited most of your people-friendly traits, or is it both?
I'd have to say probably my mother. Yeah. She's pretty easy to get along with. She makes friends easily. She's very quiet and reserved in her own way. But I'm always surprised the amount of interaction and friends that she seems to make, regardless of the fact that she seems to me to be very quiet. My dad, not so much, because he's always had that position, or has always had that position as being the authoritative person. The person, in authority who kind of meted out justice, deservedly or not, and so, yeah, I wouldn't necessarily say that I got any of that from him.
Okay. What is the least helpful advice someone has ever given you?
The least helpful advice? I'd have to take a rain check and come back to that one.
Okay.
Yeah,
all right.
sure.
I'll circle it.
Okay.
And what or who inspired you to want to be a medical doctor? I think you mentioned the what in the beginning, but
Said,
is there a who?
Was there a who? No, well, no. Initially, as I mentioned, I think I wanted to be a nurse.
Right. Mm.
Both of my godmothers were nurses. So that was kind of easy, They were in the hospital. They seemed to be, doing important, exciting things, injections, that sort of thing. It seemed very fun. But again, I didn't really. I had to learn about the difference between nursing and being a doctor. And I didn't know any doctors personally growing up, meaning that other than my pediatrician, Dr. Shuri at the public hospital.
Mm.
Yeah, well, I don't remember him. I didn't have that sort of relationship with him. He was just the doctor.
Mm-hmm.
So no close doctor, friend, family members really, no.
Okay.
So no one that I could think of who comes to mind, at least at the moment. I hope I'm not forgetting somebody and pay for this later.
Hopefully we'll have time to
to circle back and say, oh, I thought of someone. No.
You talking about Bishops and your time there and so on. How would you say your experience at Bishops High School prepared you for who and what you are today?
Well, it actually, let's see, where should I start? Well, I think I made some pretty good friends. I think persons from my childhood are still I consider them my friends.
Mm-hmm.
So that was important because, again, I think it did have a lot to do with the fact that I suddenly, in my mind, found freedom when I got to around the age of 13 or 14 where I could actually have friends who weren't necessarily just people who I played the violin with or, that sort of thing. So, what did I learn? What was the question? I guess I've forgotten what you said.
How would you say your experience?
Right, my experience. So it was a worthwhile experience. I would do it again. I probably would modify, knowing what I know now, and actually paying more attention to my schoolwork. Yeah, probably.
Okay.
That way, some of I know for a fact of a couple of teachers who actually, didn't expect me to make much of myself. Sometimes I would say, "How you let me know?"
Well, you just lead me into my next question.
Which is what?
Is there a teacher that stands out that has made a lasting impact on you? Now I'm realizing that question could be either pro or con. So take it how you want to.
Yeah, there were maybe two or so who again, I don't disagree with them necessarily because they probably had a reason. I mean, I think part of it was that they probably, because knowing that I came from such a background and such a home, I mean, I don't know that I was being any more different from anybody else, except that perhaps their expectations would be different, that I would play the violin and that I would,
Do you still play?
No, not really. I wish I did actually. I wish that was something that I continued to do because it was actually, it would be great, I think, if I was good at something like that.
Mm-hmm.
But no, I don't play any instruments. But I think that, so I don't know, I've tried to think about it myself to try to figure out what would have driven, the kinds of comments, because to the best of my knowledge, I wasn't that different from anybody else. But, but yet, there seemed to be, some sort of, prophetic sort of I would say, take or opinion about what would, happen. But clearly did.
Before I take a break, what do you tell a young girl listening to this broadcast who wants to become a surgeon, but is squeamish about blood and the long hours?
Okay, so those are two separate issues. Okay, if you're going to be a surgeon, there's going to be blood.
Right.
Yeah. So if blood is not your thing, then it's not something you learn to like. It's not something that you necessarily learn to get over your squeamish feelings about. If you truly have squeamish feelings about contact with blood, then surgery might not be the best option. Now, the long hours, regardless of what specialty of medicine you choose, especially these days, you're going to be exposed to long hours. Some specialty training programs have longer hours than others, but it's the expectation, and it's actually passed on, and probably not such a good thing, that the older people expect you to do as they did, and nobody's really been working until recently on trying to improve the circumstances or the conditions for doctors in training. For example, in New York, there are laws that restrict the number of hours that the residents can work consecutively. In other parts of the United States, not necessarily so. At least I'm not familiar with lots of other laws or rules. Maybe there are some changes, but for the most part, New York's been very progressive about that. But still, you are expected to work long hours because those restrictions still require that you don't work any more than, I think, 80 hours a week or more than 24 consecutive hours. But it doesn't mean, unless things have changed, and forgive me if anybody out there knows better than I do about the Bell Commission and any other changes, but the hours are long and the expectations are high that you will be able to function in spite of the long hours.
A very special happy birthday to my niece, Sharon Griffith.
Now here is my question, and I really need an answer. Is this the new world that you order? I really wanna know if it's so things ain't better, no better than before. Should we work with the good and the bad and give thanks for every little thing that we have? No one listens even though we complain, so that's why we call on your name. Is this the new world that you order? I really wanna know if it's so things ain't better, no better than before.
Joe, we know you love us and we know that you care. We don't want to be pushy, but we need you around here. One kind of got no soul, so they acting a fool. Flooding on the streets could have full of a bowl. But I want stick of lightning with a thunderball. Could have caused wicked Babylon and ways to fall. They all turn away from your glory. Everywhere you walk, another person I hold. But once they steal
Corruption in the system. You see, I'm sure it's not the first time that you heard them sound kissing. People are so far, some try a little thing, but at the end of it all, I see innocent fall while the wicked them standing still. Is this the new world that you order? I really wanna know if it's so things ain't better, no better than before. You say work and pray hard, you will get your reward. We're still waiting, things aren't over, bright and it's serious, still not waiting. You say work and pray hard, you will get the reward. We're still waiting, things aren't over, bright and it's serious, still not waiting.
working very hard as a survivor. We find every trick in a day book like MacGyver. But I know things safe can go and survivor. So make them never walk cause them out with your power. Aye, so we know you love us and we know that you care. We don't want to be pushy but we need you around here. Mankind not got no soul so they acting a fool. Blood in the streets could have full up
We're back with the lovely Dr. Sharon Griffith. Sharon, what skills and personal traits do you think are most important for someone who wants to become an obstetrician?
Patience.
Patience.
Yes.
How did you develop yours, Sharon?
It's still a work in progress, actually. No, for very practical reasons, you have to be patient because as an obstetrician, you are delivering babies, and babies usually come more or less in their own time. I mean, there are things that we can actually do to sometimes speed the process along, but it does require a certain amount of hours in order for a woman to give birth to a baby. So yes, it requires a lot of patience. Also, in the process of giving birth, there are usually family members and other persons who are just as anxious, if not more so, than the mother herself, the mother-to-be. So having patience to also temper that relationship, that interaction, and make it a pleasant one for everyone. Yeah, so patience, I think, is very important.
I want to go to the chat room. And Karen G said, so you were being unreasonable in school, and that is why you succeeded, because they just wanted you to be like everyone else, boring. And then Aja said, or asked, does an occasional discharge mean an STD?
Oh, those are two separate questions. So Karen probably so. It wasn't probably looked upon that way at the time, but probably so. Aja, did you say?
Right. Aja asked, does an occasional discharge mean an STD?
The answer is probably no. Occasional discharges are normal, usually. Usually what I tell my patients is that if you have a discharge from the vagina that doesn't itch or smell, it's probably most likely to be normal, or what we call physiologic. And some women notice heavier discharge at different times of their menstrual cycle. Some before ovulation, it has a different consistency, texture, amount, and after ovulation it may be different. So if it's occasional and it doesn't have any symptoms, it's most likely not an STD. However, the one way you can make certain that it's not an STD, of course, would be to have protected intercourse at all times.
And then Dennis R. said, good night, Sel and Dr. Griffith. Doc, in your practice, how do you feel about herbal medicine for the prevention and help with female hormone issues?
So it is a hot topic, right? As we become more, internet literate, and we are taking more control of our health and our choices in terms of what we want to put in our bodies. A lot of women have been looking at alternative remedies or treatments for menopausal symptoms, especially given that recently in the last 10 years or so there's been some additional information about the use of hormone replacement therapy in menopausal women. So women have become more afraid because of the mixed information probably that is out there. So just to clarify, there are some studies that show that for some women who were menopausal, who used hormone replacement therapy, there was a slight increase in risk of breast cancer in those women. What the studies found was that tended to happen in women who had already used the medication for 5 years. So that has led to a lot of fear and angst around women about what they should do for their symptoms, and so many of them have turned to herbal therapies. So for example, in my world, in the American College of Obstetricians and Gynecology and other societies, the Menopausal Society, they have information available on their websites, for example, addressing some of the more commonly used natural remedies. For example, many people want to use or choose to use things like soy or phytoestrogens. So phytoestrogens are plant estrogens. Flavonoids can be derived from soy, from things like lentil beans, flax seeds, lignans, where some studies have shown that some women have had some benefit using those products. Others have tried black cohort that's very popular in Europe. Women use that a lot. There had been some studies initially that showed that women who use that consistently for no more than 6 months, as far as the study showed, reported some improvement in their symptoms of hot flashes. And then the other thing that is also commonly used are things like red clover. But none of those things have actually been proven through long-term, prospective, well-designed clinical studies to actually show without a doubt that they actually help women. Some women, so responses have been varied. Some women believe that if they use things that are natural, meaning plant sources or chemicals or products derived from plant or natural sources, that might be safer. One of the arguments against that is that oftentimes when the natural sources are used, there has been no titration per se of the quantity of the chemical or the compound that you're seeking to ingest. There's no standardization of it. So while we may know how much medication or chemical is in the actual prescription tablet that you may take, it's hard to say exactly how much you're ingesting and what its effect might be in your system after being ingested. So it becomes tricky. So, I understand, and we certainly understand that women want to choose alternative medicines in order to help their symptoms, but there's not really good data out there that there are lots of things that actually work.
Annie said, would you say that an internal exam with the hated speculum is absolutely necessary after undergoing a total abdominal hysterectomy, even if the person is all healed with no pain or discharge?
Well, it would really depend on the reason for the total abdominal hysterectomy. If you're having a total abdominal hysterectomy because of a precancerous lesion, there may be a role for having an exam with a speculum or even continuing to have pap smears. In some women, that's indicated after having a hysterectomy. In women who are having hysterectomies for benign conditions, meaning non-cancerous conditions, then pap smears are not indicated if they have no history of abnormal paps in the first place. So a speculum exam can probably be avoided at that point. Some women have hysterectomies and still have their ovaries present. So for them, a bimanual exam by the physician with their fingers, using both hands, might be necessary, probably would be necessary. But the speculum, not necessarily. If there are no symptoms and if there's no other predisposing condition that the physician needs to, or the provider needs to be concerned about.
And R.A. asks, said, good evening to you both. Dr. Griffith, is there a special diet that a woman can adapt so as not to take HRT, which it is said can lead to breast cancer? Surgical menopause is the culprit.
Can you read that again, sir?
Okay. Is there a special diet that a woman can adapt so as not to take HRT, which it is said can lead to breast cancer? Surgical menopause is the culprit.
Okay. I am interpreting that to mean, and I could be wrong, and maybe that she would like to clarify, is surgical menopause the culprit of why she's in menopause? I'm suspecting that that's what she means, meaning that her ovaries were removed. The question is if the uterus was also removed. If the uterus was removed as well, then HRT would include just only taking estrogen without any progesterone. The reason why HRT usually involves taking estrogen as well as progesterone is to protect the uterus from endometrial cancer. The studies that were done in the Women's Health Study showed that women who actually were taking the estrogen and the progesterone, which was used to protect their uteri, were the ones who had the tendency to have breast cancer more often so than the women who were just taking estrogen alone because they no longer had a uterus. So just to clarify, if the surgical menopause was because of the surgical removal or menopause is the reason for the question, then a woman who has no uterus should have less chance of breast cancer. She's only taking estrogen by itself, according to the data that the studies that we know. But speaking about lifestyle modifications, which was the original question, again, it's the dietary aspects would include things that are high in the isoflavonoids. We talked about the phytoestrogens. Soy taken in high doses can have other effects on your metabolism, and also in women, for example, who are taking thyroid medicine for replacement. There aren't any really good studies that show that these things overall work better than hormone replacement therapy. Exercise is really important, we find. Living as healthy a lifestyle, not smoking, of course, because that increases the symptoms of menopause, not to mention all the other deleterious effects of smoking. So no clear dietary lifestyle that I can recommend that would take the place necessarily of hormone replacement therapy or estrogen replacement therapy in that case.
What are some questions you believe need to be asked that women, especially young girls, are not bothering to ask or may not know they should ask?
So I think the question about the discharge that the previous Asia, I believe her name was, asked, was about discharge. So I believe that many of my colleagues would agree that that is one of the most common reasons why women present to the gynecologist's office is to discuss vaginal discharge. And what a lot of women complain of oftentimes is actually probably a physiological or normal discharge. But I think that some women are not aware that to have a discharge is normal, and that there are things that you can do to make certain that your discharge is healthy, meaning that you avoid douching. It's a very common practice in some subcultures. Ritual cleansing of the vagina with douching products after the menses, for example. The use of other cleaning agents or medications to clean the vagina can sometimes disrupt the natural environment in the vagina, the natural flora of organisms that live there, micro environment, and cause discharge. And so there are things that some women do, I think, that can actually provoke or cause recurrences of abnormal discharge. So those are questions. So I always, as I mentioned before, I describe discharges as abnormal or normal. Usually normal discharges tend not to itch and tend not to cause itching or swelling or irritation. They tend not to have an odor. Some women experience discharges that are abnormal that either have an odor after the menses or after unprotected intercourse where there's been ejaculation, because at that time the semen is in contact with the organisms that then produce these chemicals that result in an odor. Douching, instead of making that better for most women, makes it worse. Women oftentimes douche because they have an odor or they perceive an odor, and then they use a douche, which in turn eradicates what's left of the normal flora, leaving them deficient and depleting their normal flora. So they end up having an overgrowth of the small amount of organisms that are usually there, that are usually the culprits causing the discharge. So then there's an imbalance that gets worse. So women, we encourage them to use condoms, even if you are certain that you're in a safe and monogamous relationship, because we believe that some of the transfer of a partner's organisms, even not a sexually transmitted condition, can still change the environment, the microenvironment in the vagina. So that's probably what I'd want to say. No douching, okay? Also, the other things that your doctor sometimes tells you or you read on the internet, some of those things are true. Tight clothing, lots of tight clothing, that's very popular and very convenient these days to wear tight leggings and jeans that are tight, but unfortunately it decreases the amount of circulation of air, and that sometimes can lead to abnormal discharge.
Karen G said there has been a huge section of society where birth control is prescribed to teens as early as 13 years old under the pretext of helping acne breakouts. However, there's lots of infertility and damage to organs and issues that have been arising in women pertaining to reproduction. Do you see this prolonged and early use as a contributing factor?
The short answer is no.
Okay.
and I can elaborate just a bit.
Mm-hmm.
So, Karen G suggests that adolescents are being given oral contraceptives as treatment for acne, as a subtext, or I'm not sure. Did I understand that correctly? For giving them contraception, or just for as plain treatment for it?
Well, what she said is that a youth sexual society where birth control is prescribed to teens as early as 13 years old under the pretext of helping acne breakouts. However, there's lots of infertility and damage to organs and issues. Yeah.
So I'm suspecting, or I'm going to take from that comment or that statement, that the adolescents are being given the birth control or the oral contraceptive as birth control and oral contraceptive, but it's being given to them under the pretext as treatment for acne in order to keep somebody fooled. Mainly probably their parents. This is what I'm wondering, if that's what she's asking.
I don't know.
It's hard to say. Or if it is, because usually, while it's true that oral contraceptives can have a very beneficial effect on acne, it is not primary care for treatment of acne. It may be used in someone who is seeking birth control, oral contraceptive pills being one of them, who also incidentally has acne. So the benefit would be they would be protected from pregnancy, as well as birth control, oral contraceptive pills have a beneficial effect on acne. But they're not used, they're not a primary form of treatment for acne. So I'd like to clarify, if I could, or ask her to clarify, if she's asking whether or not adolescents are being given, 13-year-olds are being given oral contraceptive pills because they need it for birth control, but for all intents and purposes, it's really just to treat their acne. Is that the question?
Yeah.
And the answer is no studies have shown that there has been any long-term deleterious effect to long-term use of birth control pills. In fact, we know that birth control pills can be very protective. Birth control pills, especially if used for long periods of time, decrease your risk of breast cancer as well as ovarian cancer, not to mention unplanned or unwanted pregnancies. And there are some other side effects or benefits, like having good skin if you don't have acne.
And Anne said, "Thank you. I was referring hysterectomy. Thank you. Hysterectomy, where ovaries, uterus, and cervix were removed because of multiple fibroids." Following up the question about internal post-op exam. You want me to try that again?
No, I think I remember the question. The question was whether or not the hated speculum should be used for the examination of someone who's had a total abdominal hysterectomy. So it sounds as if there's been no pathology, nothing found on the cervical exam, no history of cervical pre-cancer or what's known as dysplasia, then the speculum exam probably can be avoided because a pap smear isn't necessary. The only reason perhaps why a speculum may need to be used would be if there was a concern that there was some discharge or bleeding or something abnormal. Then the provider might want to actually take a look inside. So for specific reasons, perhaps. A bimanual examination is still recommended even in someone who's had hysterectomy and their ovaries removed. An exam with the hands in the vagina and using the abdominal hand is still recommended just to palpate the organs generally. But the speculum, not necessarily if the patient doesn't want to have it done especially.
Bresner said, or asked, is the use and subsequent disuse after about 6 months of, you'll have to help me with this pronunciation, levothyroxine?
Levothyroxine.
Okay. For treatment of a misdiagnosis or hypothyroidism affect reproductive capacity and or speed up menopause in older women.
Okay, let me see if I can read that back to you. Thus, the use of levothyroxine for 6 months, given because of a misdiagnosis of hypothyroidism, is that what it said?
No, let me try it again. Well, it's the use and subsequent disuse, right? after about 6 months of
Right.
levothyroxine for treatment of a misdiagnosis of hypothyroidism after reproductive capacity and or speed up menopause in older women?
The answer is no, but I'm still trying to be sure that I understand. The question seems to be that the person took levothyroxine for a short period of time, 6 months, and then stopped.
Let's try this. Bresna, can you restate re-ask the question and in a clearer way, please? Because I'm sure Dr. Griffith would like to answer it. And we'll go on to the next one. Ari said, Dr. Griffith, I was referring to menopause brought on by the removal of ovaries, etc. Thanks, you answered my question very well. The SACCB said, hello, Doc Shar. Can you offer an opinion or two about male menopause? Is it the same as irritable male syndrome? When is it likely to occur? What age, that is? Does it affect a specific race more than others?
Hi, Andrea.
Oh, you know this.
I know. I don't really have a lot of information about male menopause. Honestly, remember at the beginning of this presentation, I said I don't see male patients. However, I'm not really familiar. I know it's a theoretical construct about male menopause. I think what's recently been happening is that there have been a series of treatments made available for males for what's known or described as low T or low testosterone, which I'm not sure. I don't really have that much information about it, about the time it comes on. It is true that along with women, as we age, males and females, there is a decrease in the amount of testosterone that males make or produce from their testicles, the same as women from their ovaries. The amount or the changes or the effects are more drastic, I believe, in women, because women's only source of testosterone or male hormone, which is responsible for their sex drive, outside of the adrenal glands, which are glands that sit over your kidneys, their major source of testosterone and therefore sex drive and libido are the ovaries. So when menopause begins or comes on, women's testosterone levels fall dramatically, and that leads to a lot of the complaints and concerns that many women have when entering menopause or in the perimenopause about changes in their sexual drive or libido. The same thing probably happens to men, but to a lesser degree, because they still produce more testosterone. What levels they need to have to be able to be functioning, I'm not aware of any specific number, but then again, I'm not really well versed in this topic. So I couldn't say at what age it comes on. I imagine it happens around the same time, if there were going to be changes, as the times that women start to undergo menopause. Some men do notice a decrease, and they also have symptoms that they probably attribute to low testosterone. It may be coincidental that the symptoms of fatigue or decreased sex drive or any of the things that are being addressed may have a secondary or another reason altogether. For example, life stressors, we know life stressors, fatigue, poor health, work stressors, those are all things that decrease our level of libido or sexual desire, impact on our lives, cause depression. So it may be coincidental that low testosterone is found in those men. It may be true, not related. But outside of that, I'm just taking a guess, and I'm not really familiar.
Karen G said, well, that is the excuse, but it is really to allow them more sexual freedom. Dennis R said, Doc, after the removal of the ovaries and uterus, is no feeling in the vagina a sign of cancer from someone with the history?
The question is, after removal of the uterus and ovaries, no feeling in the vagina, if that's a sign
of cancer from someone with a history
of cancer. Depending on the kind of cancer, if it was vaginal cancer or cervical cancer, usually not endometrial cancer, there may be treatment that involves radiation in the vagina. That can certainly destroy the nerves or the perineum where sensation and feeling in the vagina originate from. Surgery itself can cause changes in innervation to the vagina, depending on what else was done. Most of our innervation to the perineum, or the area where the vulva is by sacral nerves. And if there was any damage to any of them, or any sort of therapy, perhaps. But outside of that, there may also be vaginal dryness if there's been some radiation, or just if the person is at the age of menopause, may also be vaginal dryness because of that. So directly, a person might have lack of sensation in the vagina, but it's not usually because of a sign of cancer recurring, for example.
Bresna said, thought it was pretty clear. Perhaps you can show Dr. Griffith the actual question on the screen, as you were not reading it correctly. I apologize, Bresna. And then Bresna said again, here's the question again. Can the use of the drug, levothyroxine, for about 6 months before stopping, cause a woman to go into menopause or perimenopause, or affect the ability to become pregnant?
The answer would be probably no. Levothyroxine is usually used in cases of hypothyroidism, in someone who has an underfunctioning thyroid, and usually women who have an underfunctioning thyroid usually have difficulty becoming pregnant because they don't ovulate or make eggs regularly. Some women who are hypothyroid may have that issue. So it's possible that someone may have fertility issues if they have thyroid problems in the first place. Taking thyroid medication for replacement in someone who, it seems from what she said in the previous question, didn't need it. There was a mention of misdiagnosis that was mentioned I believe that was mentioned in the previous part of the question. Taking thyroid medicine when it's not indicated can have other side effects, can cause tachycardia, palpitations, can cause hypertension, can cause other symptoms. I'm not aware of any reason why it would lead to early menopause or to infertility.
Well, actually, I'm going to read her question first because it came in last. She did say, thanks, Doc. I did mention a misdiagnosis of hypothyroidism. And anyway, Annie said, thank you so much, Doc. There was nothing cancerous. The exam is just to check if internal stitches are healed. So since I have no negative symptoms, there's really no need to go, right?
Oh, that changes the dynamic in the question a bit. The question is the question now that Annie has had a surgical procedure and hasn't been back for follow-up? Because if that's the reason why she needs the exam, in order to check the stitches, sounds like she might not have been back for follow-up. I'd recommend that she go back for follow-up, and after she's had follow-up and it's all been cleared by her gynecologist, then she can determine or consider whether or not she wants to have exams in the future. It was my impression at the beginning of the question that this is someone who's already had her hysterectomy, has already done her follow-up, and just doesn't want to continue having speculum exams. But if it's someone who's had surgical procedure and just has not yet been back for follow-up, or hasn't had the post-op examination, I think it's reasonable to do that first before deferring all other pelvic exams with the speculum.
Ari asked, Doc, how early is it safe to go back to a regular gym regimen, I guess, after total abdominal hysterectomy?
So after a hysterectomy, it really does depend on how you feel. So if you're not having any pain, most people are feeling a lot better by 2 weeks out from a hysterectomy. Some people need a little bit more time to heal. It also depends on whether or not you'd had any other abdominal surgery before, because that can actually delay or prolong your healing or cause more pain. So it's really up to the individual to start mild, moderate exercising, maybe not crunches right away, but definitely cardio, walking, maybe not jogging if you don't feel up to it. But certainly no reason why you couldn't get back once you're not having pain, or once your pain is well controlled. Most people's pain after hysterectomy is pretty well controlled by week 3 out to week 4. They're pretty much feeling okay, except for maybe the occasional twinges now and then with overexertion. So it really is a matter of going according to how you feel.
Bresna said thank you and then smiled. What tests and screenings do a woman need each year And how often should she get a pap smear?
Okay. So let's deal with how often should she have a pap smear first. I think that's easier to put together as one unit. So the current recommendations are that women start being screened with pap smears from age 21. So there are guidelines that say women between the ages of 21 and 29 should have pap smears routinely done every 3 years. Okay. If a woman is discovered at the time of one of those pap smears to have an abnormal pap smear, she may need more frequent pap smears than that, of course. Women between the ages of 30 and 65 are recommended to have pap smears either every 3 years or every 5 years. Every 3 years if she's doing it alone without any co-testing, and every 5 years if she's doing it along with a test for HPV. HPV, many may know and some may not, stands for human papillomavirus. So human papillomavirus deserves some special attention right now. Okay, human papillomavirus is a virus that is very common. It's probably the most commonly sexually transmitted infection in the world over. There are many strains of the virus. There are about 33 or so that we know infect humans. The ones that we are concerned about are the ones that we classify as high-risk HPV. So there are some strains that are low risk and some that are high risk. And when we speak about risk, we're speaking about risk with regard to cervical cancer. So let's repeat. HPV is sexually transmitted. It is responsible for 99% of cases of cervical cancer, which makes cervical cancer technically an STD. The difference is that it's not as simple as gonorrhea or chlamydia, which you can diagnose and treat right away and you're cured of. For lots of people, HPV, if not treated or if it doesn't go away on its own, can lead to, in the long term, sometime in the future, cervical cancer. But this is what we believe, that the precipitating event is the infection with HPV, and then the body has modifying behaviors or other things that makes a perfect host for cervical cancer to develop. So we can do screening for women who are 30 years and older with their pap, which is actually just a sample of the cells from the cervix and just around the cervix in the vagina, which is then looked at under a microscope for any specific changes, and paps are graded based on changes that are found, from no evidence of malignancy all the way out to malignancy. There are 5 different reports that can be given. So women are screened with pap and an HPV test when they are 30 every 5 years. It's the current recommendation. It's been increased from recently, in the last year and a half, it's been increased from every 3 years to every 5 years. If a woman doesn't have an HPV test for whatever reason, their provider doesn't do it or it's not available where they are, then testing every 3 years is adequate. Women who are older than 65, once we know that they have had negative pap smears and they have no history of dysplasia or precancer, that's the other word for precancer, then they may opt to stop screening, and usually it's recommended that for no serious cervical disease, they have screening stop. Some advocates advocate for age 65, others for age 70. There are some women who have had severe or serious cervical disease who need to continue screening for at least 20 years after their procedures were done. And for those women, they may be well over the age of 65 before their screening can stop. So that's pap smears. Hopefully I've answered clearly and concisely about paps. With regard to what other tests women should have, it really is age dependent. Some women, women between the ages of 13 and... So let me start by saying the current recommendation is that women or young women or adolescents have their first GYN or gynecologic practitioner visit between ages 13 and 15. And while that may sound really young for some mothers out there, it's 1, to make contact with the gynecologist, 2, to try to address any areas of education or teaching that can be done that may not have been done before, and also to make an assessment of the needs of that adolescent. Because in spite of what we may want to believe or be led to believe, girls at the age of 13 and 14 and 12 are having sex. And so the idea would be to identify those girls and either give them guidance that encourages them to defer sexual activity, or to provide them with the tools where they can have safe sex or safer sex.
Two more questions before a quick break. Annie said, "Sigh. Actually, I have had 2 follow-up visits post-op, but no internal exam. That is to be the last ordeal at 11th week. Could you tell me exactly what the procedure will entail? Pain threshold low."
Sorry, the last part of that was?
Pain threshold low.
I think it's not clear to me why Annie is going at the 12th week as opposed to the 4th week, or I'm not sure if there's been some complication that she's not disclosing, but most women who have a hysterectomy, and maybe not all, but most women who have a total abdominal hysterectomy are usually seen somewhere between 2 and 4 weeks for their post-op evaluation. And at that time, if everything seems to be going well after they've had their speculum exam, their bimanual exam, meaning the exam with the fingers in the vagina and the hoops and the hand on top, usually if everything is healing well, then they're just returned to routine scheduling appointments. So I'm not sure what the 11th week appointment really means, and if it is to be a pelvic exam with a speculum, then by then it shouldn't really be painful, because especially if she's had pelvic and gynecologic exams before, unless some sort of reparative surgery was done to the actual entrance to the vagina, where then there might be some scarring or some discomfort, it shouldn't be any more particularly uncomfortable than her previous exams before her surgery.
Annie said no complication, was told to come back at 11th week.
Okay, so that seems to be her provider's preference, and that's probably just the way they prefer to wait until they're pretty sure that everything is completely healed. I mean, there's no rule, no cut and dried formula that we follow. It's just been my experience that women who've had hysterectomies tend to go back in about 4 to 6 weeks for an evaluation.
I'll let a break.
Okay.
Don't you worry, baby, 'cause I love you. I love you. I can be all you want in me. All you want in me now. I'll be the wings of your fantasy. And whatever that you need, all that you need, you could ask of me. I will try to give you all that's in my life. I'll wipe away the tears from your eyes. I'll wipe them away forever in my heart. So stay sweet as you are. All you want in me. All you want in me, pretty baby. The wings of your fantasy. It's all for you. And whatever that you need, I know what you need. You could ask of me. I will try to give you all that's in my life. Everything that's in my life. I'll wipe away the tears from your eyes. Forever in my heart. So please stay sweet as you are. Stay sweet as you are. Slave driver, the table is turned. Catch a fire, you can get burned. Slave driver, the table is turned. Catch a fire, you're gonna get burned. crack of a whip, my blood runs cold. I remember on the slave ship how they brutalized our soul. Today they say we're free, only to be chained in poverty. Good God, it's illiteracy. Only a machine make money. Slave driver, table to stir, catch a fire so you can get burned. Slave driver, tables turn, catch a fire, 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 you're gonna get burned. See, every time I hear a crack of a whip, my blood runs cold. See, I remember on the slave ship how they brutalized us.
We are back with the lovely Dr. Sharon Griffith. I've heard many who do not know you and what you do. And they say after they learned of your profession how very down to earth you are. What do you believe keep you so grounded?
I'm not sure. I know what I do is important. At least I believe it's important, because I think the purpose is to do the best I can. You know, you probably remember from high school.
Mm-hmm.
I hope I don't get it wrong, but our school motto was taken from Ecclesiastes or 4, I don't remember exactly where, but basically it says, whatsoever thy hand findeth to do it with thy might.
Right.
I mean, it also goes on to say something else, but I'm not going to try to say it also in case I mess up. No, because there's no wisdom nor understanding in the grave without thou goest. I mean, I remember that part because it was a little bit scary. They talked about going into the grave, but basically the idea or the point that verse tries to make is, whatever you do, you should do with all your might, because you don't usually get another chance to do it, and you should be accountable at the end of your days. So I think that's what I try to be conscientious. I mean, and I think if you are someone who is conscientious, then usually everything else tends to fall into place, because basically you're trying not to take shortcuts and you're trying to just do what you believe to be the right thing, and that makes it easier. If it comes across as being down to earth, then okay, but I don't necessarily see it that way. I just see it, I'm actually a little bit of an anal type personality to some degree. I just like to have the I's dotted and the T's crossed for the most part. And, you know, maybe it comes out of that whole thing with, you know, always being told that you cannot lie and you cannot steal. that basically those things are still inherent, and so, and it kind of fashions what you do and how you do your work.
I'm going to go rapid fire and ask you some questions.
Okay.
See how fast you can answer them.
Because
general questions.
Okay.
But time is creeping up on us, and even though you promised you're going to stay some extra time, which I'm sure the audience appreciate, what is the most complicated case you had to work on as an obstetrician?
Oh dear.
There, you want me to get back to that one?
No, well, yes, maybe you probably want to get back to that one.
What do you think is the biggest health care challenge facing women today?
I think there are several, but one of the very important ones, I think, especially in New York City, probably because of my exposure to where I work and the types of patients that I see, the challenge remains having access to quality healthcare. Remains a challenge. And there are lots of reasons why that's a challenge. One, because physicians are becoming more and more strapped for time because, for many reasons. One, of course, is monetary. I mean, compensation and that sort of thing makes it so that physicians find themselves having to see many more patients to take care of whatever their financial requirements might be. So that tends to cut into the amount of time that patients have with their providers to begin with. But also, there are some women who are not able to even afford to go to the doctor. So hopefully things are going to be changing soon. There are laws in place now that make it easier, I believe, or will make it easier for more women to actually have access to healthcare. And for that, I am very grateful. I mean, but that may be, I try not to be political about the subject, but when you see women who have no access simply because they can't afford to pay or are willing to pay but can't afford the cost because healthcare expenses are very high, especially, that continues to me to be a challenge. But I also meet women maybe once a week or at least once a month who will not even benefit from these new rules or these laws because in spite of everything that may be available, they may not be eligible, and so they continue to be in the black hole of patients who can't get medical care in a place like the United States where medical care should be so easily available.
Looking back on your medical career, do you have any regrets?
I was actually hoping you wouldn't ask something like that. Only because...
What about a softer one?
No, I can try to answer it. It's difficult. People ask me if I had to do OBGYN over again, would I do it? And the answer is probably yes, because again, it met the criteria that I had for something that I wanted to do, meaning that it allowed me to be a surgeon as well as an internist, more or less, in order to practice medicine and to be a surgeon at the same time. So those things about the specialty hasn't changed. The amount of energy and exhaustion that come with the specialty can oftentimes lead some practitioners to early burnout, which is, because of the long hours and the stressful environment, especially in the obstetrical aspect of things with, there are lots of legal issues that can come up, and therefore some practitioners are easily burned out or burn out after a period of time. So it's a stressful profession, and so would I do that again as opposed to something where my classmates, are having a slightly easier life? Probably, looking back, but I'm not sure that I would enjoy it as much as I've enjoyed what I do.
Do you see many women with abnormal pap tests, and how do you counsel them?
Is that a question?
Yes.
From a
No. That's for me.
Yes, we see women with abnormal pap tests often. Not always is it a harbinger or a diagnosis of something that will be terribly wrong. So it really does depend on how the pap smear has been evaluated and what is the diagnosis given by the pathologist, and you counsel accordingly. For women who have mild changes in their pap smear, may just require a follow-up exam, another pap in a year or so. Women with more extensive or suspicious conditions on their pap need follow up. There are procedures that there are algorithms that we follow basically when we are evaluating a woman who has an abnormal pap. What are not the precipitating factors? What was the previous history of the abnormal pap? Has there been one before? We take all that into context in determining whether or not someone needs to be seen for a follow-up procedure, which is called colposcopy usually. Colposcopy means looking at the colpos through a scope. Just to clarify for anyone who's interested in where the words come from, the colpos is the vagina and cervix at the top of the vagina. So we do that procedure for some women who have abnormal paps, and some women whose paps show that there is significant precancerous disease. Then they may be offered therapy in the form of surgery to remove the diseased part of the cervix. So the whole idea about pap smears is that they are done to screen for cervical cancer. And because cervical cancer is something we can certainly screen and diagnose early in its early stages, or even in its pre-cancer stage, then that becomes important that women have access to that at least every 3 to 5 years as is recommended.
Someone asked me to ask you this. Mm-hmm. What do painful periods mean?
Okay, so there are two types of painful periods, meaning there's a painful period that is called primary dysmenorrhea, dysmenorrhea being the word for painful periods, and then there's secondary dysmenorrhea. Secondary dysmenorrhea is usually what most people or many people encounter or complain of. So primary dysmenorrhea is dysmenorrhea that is there because of no other known reason. It's something to do with your uterus makeup, your chemical makeup, but it's not caused by a structural abnormality or another disease or disease process or condition. Whereas secondary dysmenorrhea would be fibroids, for example, endometrial polyps. There are conditions called adenomyosis, things of that nature can cause painful periods. So it depends on when, in the context of when the pain started, if it has always been there, okay? Patients who tend to have primary dysmenorrhea sometimes have a condition called endometriosis. And patients who have secondary dysmenorrhea need to be evaluated to see if there's any reason why the dysmenorrhea has begun after not being there in the first place.
Esther in the chat room said, "Good evening, Selwyn and Doc." Good evening, Esther.
Good evening.
Dr. Griffith, have you ever had the misfortune of losing a patient in spite of all your efforts? If yes, what has helped you through that? How do you overcome this?
I have actually never lost a patient directly, personally I should say, but I have been actually present or around when there has been a patient whose life we were not able to save, on maybe 2 or 3 occasions. And it is one woman was a perinatal patient. She was a pregnant woman, and unfortunately she succumbed to the infection with the H1N1, the flu virus. And women who are pregnant have a significantly increased chance of dying or becoming extremely ill from influenza infection when they are pregnant. So this might be my moment to actually make a plug for getting your flu vaccine, whether you're pregnant or not, but most so if you're older and pregnant. So yes, that was a case where a woman, so she left behind an infant, a neonate just born, and that was stressful and emotional because clearly there was not much that we were able to do to save her life. But you recover from that because one, we are not gods. We are human beings who have been trained to be able to help in certain medical conditions, and some of it, of course, I think still depends on a bit of faith. For the most part, you console yourself, or you consider the positive or the good that you've done, and you not to negate or to dismiss what has happened to someone that you've lost, but you have to put it in context. And as long as you know that you feel that you've done everything that you can, then that's what you've done.
Steph K said or asked, why would there be an abnormal pap smear and then get a clean bill of health after colposcopy? Colposcopy. Should the patient be worried?
Okay, I'm sorry, I first interrupted in the middle of the question, so please repeat it.
That's my fault. Why would there be an abnormal pap smear and then get a clean bill of health after a colposcopy? Should the patient be worried?
So a pap smear is a screening test, as I mentioned. So they are neither very sensitive or very specific. Okay, that's why they're screening tests, so that we are prompted to go on to look for any other evidence of disease. They're not diagnostic tests. There are many things that can make a pap smear appear abnormal to the person, the cytotechnologist or the cytologist who's evaluating the pap smear. For example, if a woman actually has a discharge, an abnormal discharge at the time that her pap is done, there can be evidence of inflammation. If a woman is pregnant at the time her pap is done, there may be changes in the way the cells appear that are actually from the influence of the pregnancy hormones that cause cytologic changes that appear similar to an abnormal pap smear infected with HPV. So, with a cervix infected by HPV. So, there are times when we do a test, take a look with colposcopy, and we don't find any evidence, or the pap reverts back to normal. That happens from time to time, actually not so infrequently that we actually look for disease and we aren't able to find any. If it continues to be the case, that's why a pap test and screening and colposcopy aren't necessarily meant to be one-time interventions or evaluations. It does require continuous follow-up in the designated time frame. So a woman who's perhaps had an abnormal pap smear and has had follow-up and no significant disease has been found should be glad, but also should know that that's not an excuse or reason to not follow up at the prescribed time for follow-up.
I know you've taught obstetrics and gynecology at Columbia for some years. What is the most, what advice do you give medical students mostly?
Well, actually, I need to correct you about that. So I was an assistant clinical professor, and yes, there was some supervision of the medical students, but mostly my contact was mostly with the residents when I had contact with the residents. So medical students, we did have supervisory responsibilities when I myself was a resident. That's usually when you tend to supervise the medical students. And what advice would I give them about? I needed to clarify my position before.
Well, that's okay. What advice did you find yourself giving them mostly? What is the most frequent advice you give to them?
Well, in medical school, the most important thing you can do, in addition to just doing your coursework, which if you don't do your coursework, you'll not be very knowledgeable when you leave medical school, but a lot of what you're taught in medical school, unfortunately, may not be applicable to your specialty, in the sense that, everything that I've learned in nephrology it does not apply, or I don't need to call on all of those, that knowledge base in order to do what I do. So lots of what you learn may not be able to be used practically, but it's the idea is to be able to focus on knowing where to get the knowledge you need and knowing how to apply it when you need to. Also, medical students need to enjoy themselves while they're in medical school.
Well,
have a lot of fun in medical school.
I have one more question that may require a long answer, and then truly rapid fire. Okay. What are the most important things that women can do to protect their reproductive health?
Yes, that's a good one. So to protect your reproductive health, I'm going to go through the list as quickly as I can. Don't smoke. Don't have unprotected sex, meaning use condoms, unless you are 100% certain that you are in a mutually monogamous relationship. If that were the case, then certainly you may, if using other contraception until you plan to be pregnant, have unprotected sex. But that again should be at discretion, with the knowledge that you are putting yourself at risk regardless of the circumstance, unless you are 100% sure. So the reason why I stress this point is because lots of questions or problems that arise with reproductive health have to do with not planning ahead. So women who plan to become pregnant or want to become pregnant need to recognize that the impact of some of their actions may have on their ability to become pregnant in the future. For example, an infection with an organism such as chlamydia or gonorrhea can seriously damage a woman's prospects for becoming pregnant in the future, either by causing damage to her pelvis or her tubes, making it impossible for her to be pregnant. So, as I say, oftentimes mostly to the younger women that I see, that there's no restriction, I believe, to the act or the desire or the engagement in sexual activity. What needs to be done when you've decided that you want to engage in sexual activity is to do it responsibly. And to do it responsibly means that if you don't want to have an unplanned pregnancy, you should take precautions and do what's necessary to not become pregnant, so that when you are ready to become pregnant, you stand a good chance of being able to be so. The other things, smoking cigarettes, smoking marijuana. I mean, I know that there may be other benefits to marijuana use, but marijuana can sometimes slow down the action or movement of the cilia that move the eggs along, and even in some cases contributes to male infertility, we believe. So those things, of course, at your discretion, should be minimized. The other things women can do to protect, not their reproductive health per se, but for women who are having unprotected intercourse, who would not mind being pregnant, I believe it's important that they also remember to be certain that they're taking enough quantities of folic acid. That's one of the easiest things that women can do to help have a pregnancy or deliver a baby that doesn't have neural tube defect, spina bifida. It's something that's easily fixable by incorporating it into the diet. So oftentimes we see women, for example, who are having unprotected intercourse, they're not using any method of contraception, who become pregnant and are quite happy with the fact that they're pregnant. It was neither planned or unplanned, it was something that was reasonably accepted. But they hadn't been taking any precautions in terms of, or doing anything special or necessary in terms of trying to make certain that they have the best pregnancy outcome. And so, most of the brain and spinal column are formed by the 6th week of pregnancy, when a woman is 6 weeks out from her last menstrual period. 4 weeks usually the case. That's usually when most women don't know that they're pregnant. So the vitamin, which is folic acid, needs to be on board. We like to believe that it should be on board for at least 4 weeks before conception. So if women are not aware that this should be actually prenatal vitamins while we give them to women, the most important time to actually be taking those vitamins are before conception. Same thing is true about protecting your reproductive health in terms of making certain that you've got all your immunizations that you need to, that you're up to date, that you're not overweight or not pre-diabetic. There are women who are overweight but who are not pre-diabetic, that you're getting regular exercise. Those things increase your chances of not having diabetes or preeclampsia or hypertension in pregnancy. So those are some of the things that you can do to maintain your reproductive health. But I think the most important thing would be to avoid coming into contact with infections that can cause harm, and to avoid practices that can cause harm, and to avoid excessive weight gain.
Do you have a favorite type of music, and what will that be?
I have a few favorite musics. Techno is definitely one of them, and I like it's called trance or lounge or acid jazz, lounge music, and of course I like reggae, dancehall,
of course,
any variation thereof, and of course I like soca, calypso, any variation thereof. Yeah, so it's not easy to pick one particular type, but I'm not really a big fan of rock music, although sometimes there are some particular songs that are pretty cool. But for the most part, things that get me going are usually world music, sort of anything with a maybe Arabic sort of bend. It really depends. As long as there are lots of drums, which all those that I mentioned have in common.
What are you most proud of?
I'm most proud, I believe, I would say that of my ability to get up every day and keep going to work in spite of some of the obstacles that sometimes we face in doing our jobs, and being able to know that sometimes there's actually an impact that can be made. I mean, when I get the sense, I mean, lots of the time, you know, there isn't any necessarily any sense or of not necessarily, I don't want to use the word appreciation because that isn't really why we do what we do, but some sort of positive energy coming back, an acknowledgement that, you know, something good has come of this interaction. Many times that's not there, but sometimes even if it's not said, even if it's just a glance or a look, just the appreciation that you were able to do something to help. And sometimes, you know, a lot of it is rote and routine, but sometimes there are times you can actually make an impact and go outside of the norm to do something to actually help someone and make a difference. And so I'm proud that I have the ability to do that.
I'm going to slip into the chat room. Esther said, thanks for answering my previous question so sincerely. What causes organ prolapse after surgery? Can exercise contribute?
So, first of all, Esther, hello. Organ prolapse can happen with or without surgery. Actually, there are some women who have never given birth or had surgery who have organ prolapse. So, yes, your chances or risks of having organ prolapse increase with parity or having given birth or having, for example, a hysterectomy. And the reason why that happens is because once the cervix is removed, the supports that hold the uterus and the vagina in place are no longer there and are no longer as sturdy. They are oftentimes there, but not as sturdy perhaps. And so with a combination of having lost some uterine support, as well as the effects of aging, where women, for example, menopausal women lose estrogen, which is also important and necessary for vaginal health and well-being, then there can be organ prolapse. Does exercise contribute to it? I don't believe in any real significant way. I don't believe that jumping, you know, doing jumping jacks or working out is going to accelerate or cause vaginal prolapse or pelvic organ prolapse. I think it's already inherently there in whatever procedure came before, or your physical state to begin with. Although, as I must again reiterate that there are some women who've had neither surgery or children who have organ prolapse. Some of those women may find that they are significantly overweight and therefore they carry a lot of intra-abdominal mass, which may be causing pelvic pressure. So all of those things can contribute, but not one thing in particular.
What profession other than yours would you like to attempt?
I should be an actress. No. What profession other than mine that I would like to attempt? I actually don't know the answer to that question. As I said, maybe some sort of something to do with the arts. I don't really know that I'm very creative, but maybe I'd like to discover if I can be. You know, I'm not sure. Design something, paint something. I can't do any of those things, but it would probably be interesting.
Have you ever tried?
No.
Okay.
I actually was.
There's room for discovery then.
There's room for self-discovery. There is, and yeah, there's still time for that. I once said recently to someone that in spite of all the time that it took to get to this place and in the education, I just not recently, but then I had to learn the lesson that the only thing that I am actually trained to do is this thing. So, this is self-awareness.
That's interesting. Annie said, just one more question, Doc.
Sure.
What is the exact procedure for the post-op exam? I mean, apart from the speculum, is anything else done or used? In which cases is sodium nitrate used?
Sodium nitrate?
Sounds like an exam question, Sharon.
No, it's not I don't think it's an exam question. At least I've already taken the exam, so it doesn't matter anymore. But let's see. If I remember correctly, Annie had a hysterectomy where she had her uterus and her ovaries removed through the abdomen. And she is supposed to follow up with 11 weeks for her post-op, her final post-op check. that exam usually would most likely be one to look at the abdomen and make certain that the incision is healed nicely. A speculum examination, as we mentioned before, just to make certain that the cuff is healed nicely, the place where the cervix was removed when it was taken out abdominally. I'm not sure I know what sodium nitrate is and why that would be used.
Okay. Well, looking back at your accomplishments, what would you tell the 13-year-old Sharon at Bishop's High School?
So we come back to that.
Yes, we do.
Considering how it all turned out,
Right.
I'm not sure if I would necessarily tell her anything. It didn't really turn out so badly, right? I don't think so. Initially, okay, so maybe I would tell her. So initially, when I first wanted to be a doctor, I was going to. You have these visions. Some people have visions of wanting to have a family and then a certain number of children and a dog and a house and a pool or whatever. And then there are some people who have other ideas. And so mine was, I was going to, of course, go study and work for PAHO or the World Health Organization in some really exotic place, doing good. And of course they would pay me in American or British cash so that I could live in Guyana and live large. That was the plan.
That was the plan.
The 13-year-old Sharon, maybe I would tell her that that's not really how it works. Yeah. But other than that, I don't think that anything that really she did. Paying more attention, probably would have helped. For example, I did Spanish for 3 years or so for CXC or whatever, which, while it didn't manifest itself, it didn't seem as if I was actually maybe paying a lot of attention at the time I did the CXC. I did it for a year and a half in college, and you know what? I was able to ace it.
Oh, well, congratulations.
Because I actually remember, thanks, Mr. Marks. That's what I'd like to say.
God, that's a name I forgot.
Gracias, Mr. Marks. But in the end, it didn't probably hurt me as much as it would have if I didn't have the opportunity to more or less, I would say, start over or augment or just fine-tune my behavior practice and just focus on what I needed to do.
By the way, we're having a reunion next year.
Yes, I'm aware.
Will you be attending?
It's my intention to be, but I'm not so sure. There may be something that has come up that I might not be. But I'm hoping to.
There's a but and a maybe.
There is a little but in there. Yes.
Okay. You're standing in front of an audience, perhaps in the auditorium of Bishop's High School, looking at some expectant faces and some starry eyes. What do you think your opening remarks would be to them?
Wow, Perry Hall looked the same.
Okay. Moving right along. What do you look forward to doing on weekends?
Oh, these days, just relaxing. These most recently, it seems as if Monday just comes really quickly, and that's how I know I think I'm getting older, because I think that's what older people always said all the time when I was younger, when I didn't really think, the weekend seemed to last forever back then. But recently, it's Friday evening just seems to meld right into Saturday and Sunday, and then there's Monday. So what do? I try to relax or get something good to eat or look at TV, catch up on the news. I find myself looking more at the news than I did before, which is another sign of aging, I believe.
I'm going to risk this question.
Okay.
What do you do to de-stress?
Oh, I've been going to the gym.
Okay.
Yeah, partly out of guilt and out of guilt, but for two different reasons. The guilt reason is because I know I should, because really and truly it's the only way to, try to stay fit. And the second guilt reason is because I tell my patients to go to the gym. I try to put myself in, so when I go, it's hard working out, doing something physical to maintain your body weight or to lose weight. It's very hard. One of my biggest concerns, and I know you didn't ask me about that, but I have to get on the bully horn, and to say that, it's more and more concerning to me as a gynecologist, as a doctor, as a woman, about the amount of obesity and overweightedness that seems to have overtaken our society. And I'm speaking about it not necessarily from an aesthetic point of view, but from a practical point of view. And it's not easy. It's very easy for me to say you need to exercise more. So there have been studies that show that, women, patients in general, but mostly because I only take care of women, that women appreciate, or will notice or say when asked in surveys, did your doctor address the issue of weight and diet and nutrition with you? Many women will actually respond no. Why? Because really and truly, the time to deal with all of the other issues leaves hardly any time. So that's part of the reason when you mentioned before, one of the things that I am concerned about, or I think is makes an impact in the care of women. We talked about limited access to care, and I mentioned in that as well the limited amount of time that doctors get to spend with, or providers get to spend with their patients. One of the things that kind of gets put to the side when you're dealing with issues that are more important maybe to the patient at the time, for example, the discharge or the mass that they palpated in their breast or their pelvic pain or whatever the reason that brought them to have had them come to the gynecologist in the first place. Oftentimes it's easier to kind of ignore the issue of weight and the impact that it can have on so many aspects of their life, including the examination itself. I mean, more and more, it's becoming more and more difficult for us as caretakers or providers of health care to women who have to perform pelvic examinations to do those easily, because more and more women are more and more overweight. And while it's a difficult topic to talk about, and it may upset some people to hear me say that, it is a fact. And I don't know that there isn't a quick answer or a quick solution. It's not just a simple matter of not drinking soda or telling someone to exercise. There need to be behavioral changes and the recognition that all of this is not good and cannot be good. So it's a constant for me. It's a thing that I try to bring up at every visit in some form or the other, even if it's just a question about, are you exercising, or making suggestions about how you can incorporate exercise into your life to try to work on either maintaining your weight or lowering your weight. So I just thought I should bring that up.
Annie said, silver nitrate. Relative to a question before.
Okay. Yeah. Okay. So silver nitrate, or we use silver nitrate sticks. It's a cauterizing agent. The one possible role for the use of silver nitrate at the time of a post-op examination is if the patient has residual granulation tissue. So when the uterus is removed along with the cervix, then the vagina is just basically a blind pouch that is closed off at the top. And where the sutures are, sometimes there can be an inflammatory response, an overreaction to the suture material, and that's called granulation tissue. It just looks like a bit of polypy material, and sometimes it bleeds with touch or it bleeds with intercourse. And usually we tend to use silver nitrate sticks to cauterize and just burn it away, and then it sort of falls off and not dissolves, but it goes away. So that will be the only reason that I can think of off the top of my head as to why silver nitrate might need to be used post-operatively. So she did not mention whether or not there was, she actually said, I believe, that there were no complications. Mm-hmm. Right, so outside of that, I can't think of why else silver nitrate would be used.
All right. Esther said, thank you so much, Dr. Griffith, for your clarity and patience. This has been a great learning experience. Do continue to make your sterling contribution to society. Karen G said, wow, gosh, happy you're talking about the weight issue. And so I go back to my last three questions. Finish this sentence. The best part of Sunday evening is... Did I put you on the spot?
No. I actually don't like Sunday evenings very much.
Why is that?
Because they are followed or succeeded by Monday mornings. So Actually, so the best part of it is just winding down and mentally preparing for Monday. And so usually we look at a movie or something just to wind down and just to like savor the last part of Sunday before Monday. It's a lot better now than say 3 years ago when I had a different type of job, because on Mondays I tended to do my on-call stint in the hospital, and it was usually a 24-hour call. So that usually gave me a lot of anxiety, yes, about Mondays. So that's why Sundays have just never been really good, because Mondays are usually pretty stressful.
What is next for Dr. Sharon Griffith?
I'm not sure. I actually don't know.
Good
yet.
answer.
I have to embark on that whole self-searching, it's not alternate career, but maybe co-career. I would like to be able to, and I know I say that and then to myself, and then I don't really seem to ever do anything really about it, so that's procrastination. But really, to become more involved actually, is I probably seem very enthusiastic or very fervent about the issue that we were just talking about, the weight issue. So there are two areas of medicine or healthcare that really pique my interest, and one is the obesity problem, and second is teen pregnancy. To put it out there, women in the United States, on the average, are having sex about the same age as women in other parts of the world. For example, in Europe, in Western Europe, they're having the same amount. They're starting to have sex at the same age, somewhere around 13 or so, for the most part, 14 maybe. But they're not having as many pregnancies as women in the United States, as adolescents in the United States, and that probably means that they're using contraception. That once they've decided that they will be sexually active, they're doing so responsibly, either being forced to by their parents, or to some degree, or being given the tools that they need in order to enjoy sex, if that is their choice, as well as still be responsible about it. And I think that there are many impediments here in the United States to us taking a common sense approach. I don't believe, contrary to what one of the commenters said earlier, implying that oral contraceptive, I think the implication was that oral contraceptive pills for other purposes might be masking the use of oral contraceptive pills for contraception's sake. I don't necessarily agree with that, but I do believe that the responsibility should be shared and held not only by parents, but any elder or person who has the ability to impact a young woman's decision making. Sure, we want abstinence if we can get it. We absolutely would prefer that, because we know that, the longer you delay your first coital act, the less likely you are to have multiple sexual partners, and the less likely you are, for example, to incur or become infected with HPV. Just to not even discuss the other infections that you might acquire, which decreases your chances, therefore, of getting cervical cancer. So while there is a vaccine, and that brings me to another topic about the vaccine, but while there's a vaccine that can help to prevent infection with some of those viruses, it isn't the answer. So the answer is more about, I believe, working with adolescents to, one, be able to appreciate their bodies, to understand how they work, because that's another topic probably for another time, but it's very often commonly found that adolescents, younger women, don't really have a good handle on how their bodies work. They know when they sense pleasure from it, but they don't necessarily appreciate all the other things that go hand in hand with being able to have pleasure. So I think we need to focus more on practical ways to engage adolescents so that we can decrease teen pregnancy and allow women to become pregnant when, one, they feel more capable, okay, and not necessarily when society dictates that they should have children, but when they are more capable of being responsible parents.
Before I ask you the last question, which I ask everybody, I'm just going to go into the chat room for a second.
DSACCB said, speaking of time, is there a standard amount of time physicians allow for each patient? 10 minutes, 15 minutes?
There isn't a standard amount of time that physicians allot to each patient. It's usually the person planning the physician's schedule. Hopefully that gets me off the hook. But honestly speaking, most, and maybe not all, it really depends on if the provider has the luxury of having a well-established practice in a very, an area where the median income is really high and the patients are willing to pay what the physician thinks he or she is worth for their time. So in those situations where, in other words, in cases where patients are private patients or cash paying patients, a physician's schedule may actually be less booked than in the practice of someone who is receiving compensation from insurance companies or is actually working in underserved communities where patients are not able to pay well. What that does is that in order to meet overhead and in order to pay the staff and in order to meet financial responsibilities, physicians have been forced to see more patients. Therefore, because there are only 8 hours in the workday, it means that patients are seen in more or less 15-minute spots. It doesn't always work out that way because, of course, 15 minutes can go so quickly that some physicians will actually stay over, but then it does put a burden on the practice, usually, if everybody goes over. One thing I think that can make I'm preaching now, I know, but I feel as if I must. One thing that can make the experience easier, everybody complains. People complain, patients complain about the time they spend waiting in the doctor's office. Patients complain and then doctors also complain about the overload of patients that they're meant to see when they're being scheduled. So there's back and forth, right? Nobody's really happy. Things that can make it go a bit smoother are patients who come on time to their appointments. So it has become common that the expectation is that the patient will wait. I think that's as rude as the doctor waiting. I think it works both ways. If the doctor has shown up on time, then it's, I think, reasonable to expect that the patient shows up on time. And oftentimes, that's not what happens. And then what ends up happening is that everybody who comes later ends up suffering and probably getting even less time. So, if everyone would be introspective and take a moment to think about how does my being late affect me the next time when I am coming after somebody else who's late, then perhaps maybe there might be more understanding. So there's no direct or quick answer to the question, but that's the best I can offer. There is no necessarily to time. I've gone over the time necessarily, that meaning that I am sometimes still seeing a patient at the time another patient is scheduled, either because there were matters that needed to be taken care of, or my day is just going that way.
And Annie said, thanks. I was just wondering about the silver nitrate and wondering if it would have to be used in my case. From the answer you have given, I don't think I have anything to worry about. So, to my last question, which I ask every guest, what makes you laugh out loud?
Lots of things make me laugh out loud. It's hard to pin it down. I laugh out loud quite a bit sometimes. I mean, I like someone who has a wry sense of humor. I'm not really fond of comedians who tell jokes, for a laugh, but because those are usually contrived. But someone who really has a good sense of humor can make me laugh. Someone who.
How do you feel? I've been thinking about you, baby. I've been wondering how you must be feeling without me there. I understand how hard it could be when we're not together. But I appreciate the support you give to me. That's why I called to say I can be all you want in me. I'll be the ones of your fantasies, and whatever that you need, you can ask of me. I will try to give you all that's in my life. I'll wipe away the tears from your eyes. You're forever in my heart. So please stay sweet as you are. I'm on the road, I meet many people, but none of them compares to the lady I got waiting for me with open arms at home. I never forget the love that we share. It's so special. I know I've been heaven blessed. You're my angel from above. And I live for your love. I can be all you want in me. I'll be the ones of your fantasies, and whatever that you need, you can ask of me. I will try. I'm gonna give you all that's in my life. I'll wipe away the tears from your eyes. You're forever in my heart. So be sweet as you are. Baby, it hurts me when I'm out here without you. And I know you cry for me, 'cause I feel it, 'cause I cry for you, I cry for you. One thing you don't have to fear, I'm not gonna leave you. Don't you worry, baby, 'cause I love you. I love you. Another confrontation between my wife and myself. Oh yeah. Now how the hell me going get out of this one? Another problem again. The wife asks if there's another woman, or is she just a friend? In the back of my mind, I knew I wasn't guilty of.
Just has a sneaky, wry, dry sense of humor. Those things that some things people say just make me laugh. Commercials make me laugh sometimes. Some of them are funny. There's one, for example, right now with the Swiffer. They're too old, like I think they're Jewish people, I'm not sure.
Yeah.
They make me laugh every time I see them. I think his name is Artie or
Yeah,
Artie.
yeah.
And he goes, "I'm not a sweeper." Right, exactly. That's how stuff makes me laugh, because it's hilarious.
And the SACCB said, "Thank you, Selen, Dr. Shar." And Sharon, thank you.
You're very welcome.
This has been very informative.
I hope that
I enjoyed it. You
I
hope?
didn't cause any agitation among your viewer population.
Agitation?
Yes, I didn't cause any distress, meaning that things were clear and they're not even more perplexed than they were before they joined on. I hope I was able to clarify some things, and it was certainly a pleasure. I didn't realize I had so much to say. I thank you for giving me a chance to be on my soapbox about the issues that matter to me too.
You're welcome. Very welcome. Dennis R. said, "Selen, Dr. Griffith, thank you for the great conversations and excellent info. Thank you for sharing, Doc. Good night." So Sharon.
Thank you.
Good night.
Thank you for having me, and good night.
You're welcome.
Good night.
And so I go on trying. gone in every way until the sun broke through. It wasn't in the sky, no. The light came from her eyes. She turned the gray sky blue. On that cool September morning, I saw her in the rain. To me, she was a movie star to the world. She was just Jane, yeah, but she's everything to me. She's just Jane, and she's all I'll ever need. She gives more than she takes, and she takes my breath away. Oh yeah, in the world's eyes, she'll always be just Jane. But because of her, my world has changed. Yes, it has. I tried to catch her eye as she was walking by first. At first she seemed confused. I saw she wasn't sure. My smile was meant for her. I said, I can't help notice you. And when you find that someone special, you don't let them slip away. So tell me what your name is. She answered by saying just Jane. Oh, oh, oh. She's just Jane. Oh, oh, oh. And she's all I'll ever need. She gives more than she takes, and she takes my breath away.
Baby, I'm not gonna wait no more. You know that I love you, so this is what I gotta say. I've been really trying, baby, trying to hold back this feeling for so long. And if you feel like I feel, come on, come on, come on, come on. Let's get it on. Let's get it on. Let's get it on.